Want to impress examiner? Nail step-by-step vaginal hysterectomy on dummy. Assalamu alaikum, how are you all? As exam is very near, so I am creating this quick video on vaginal hysterectomy. In exam, more or less, this type of dummy will be provided and you have to apply the clamps accordingly. In the exam, a dummy will not be a 100% of actual uterovaginal prolapse. Examiner will check your knowledge, that you know the steps and you know the instruments and how you apply those instruments and the safety points you remember or not. In this dummy, you can see the blue ribbon from below to above shows uterosacral ligament, the red ribbon shows uterine vessels, and the above blue and yellow ribbon shows adnexal structures, or we can say the uterovarian clamp. In exam, you will start systematically that you will take the history, rule out contraindications, and explain the complication, take informed consent, involve anesthesia team, and after induction of anesthesia, clean drape the patient and do bimanual examination to confirm the findings. Yellow part is for the bladder and the maroon one is showing uterus. In real patient, uterus is not visible like that, but we have to show the attachments and we have to deliver the uterus out in the dummy. So just imagine this part like in the real patient where uterus is not visible from outside and perform the steps. Hold the anterior and posterior lip of cervix with valsalem and see the extent of bladder by bladder sound. 1 centimeter below the demarcation where bladder ends, you will inject diluted adrenaline solution circumferentially in order to have a cleavage plane and also to reduce the bleeding. Then incision will be given there where you injected adrenaline solution circumferentially or diamond shape incision. And this is real patient's picture. I have included this picture to have an idea that you people will imagine that how we will give incision in the real patient and how we are mimicking this incision on the dummy. Then after incision, we will try to separate the vaginal epithelium from the cervix. Once it is separated, the vaginal epithelium will be pushed upward and the cervix downward. And then there will be peritoneum anteriorly to open the vesicouterine pouch and posteriorly to open the pouch of Douglas. It is a safety point. If you open the pouches and then apply clamps, then you can avoid the ureteric injury. So after opening the anterior and posterior pouches, you will deliver the uterine fundus and then will apply the clamp in reverse order as compared to the transabdominal hysterectomy. Here we will apply first clamp on the uterosacral and cardinal ligament and second on the uterine vessels, and third one is on adnexal structures or uteroovarian. Now you people can see the first clamp is being applied on the uterosacral ligament. Curved clamp is being applied and then it is cut and ligated, clamp, cut and ligated. Then comes the second one, that is uterine vessels. Then you will apply the curved clamp on the uterine vessels and clamp, cut and ligate. Again, cutting technique should be flowering. We will cut in the bits and the pieces in order to avoid the slippage of the ligature and to have some good tissue in the clamp. And then we will apply the clamp on the adnexal structures or uterovarian clamp. Then oophorectomy can be performed if indicated and number of clamps can be increased depending upon the patient's anatomy. And then uterus will be taken out. Then hemostasis will be secured, pedicles will be ensured and vault will be closed. There is another step called mechal culoplasty, which is done in order to avoid the vault prolapse in the future. In this procedure, we pass the needle or thread through one side uterosacral pedicle, then from the peritoneum of the vault, and then from the other side's uterosacral ligament pedicle, and then tied it together.